Yes, good evening, everyone. So it's my pleasure to warm welcome you all to session three of our additional thematic lecture series and organized by the Journal of Marginalized Communities and Social Justice in collaboration with Blue Ocean Insights Private Limited. Today's session focuses on highly important and timely theme, so health inequality and marginalized populations. Health inequality remains one of the most critical challenges in contemporary societies, particularly affecting vulnerability and marginalized groups. Differences in access to healthcare, quality of services, and health awareness and broader socio-economic conditions continue to create significant disparities in health outcomes. As highlighted in today's session context, uh, the content, understanding these inequalities through the lens of social determinants such as income, education, and environmental is essential for developing inclusive and evidence-based solutions. So this session will provide valuable insights into how structural, social, and philosophical factors influence health, behaviors, and access to care, while also encouraging participants to think critically about research opportunities in this area. So it is now my great honor to welcome our esteemed research person, Dr. Madhav Dasa, a distinguished medical administrator, business, public health leader, and hospital director, and at the same time with extensive expertise in health systems, patient safety, and also quality improvement as well. So we are truly privileged to have him with us today. So let us warmly welcome Dr. Dharmadasa to begin the session.
Thank you very much for that warm welcome. Good evening, everyone. I'm Dr. Madhav Dharmadas. So, shall I share my screen or is it?
Yes, Doctor, we can see.
Yeah. Today I'll be speaking on this topic: health inequality and marginalized population. So, this is not just even though I'm from medical background. My background is medical, but it's not about a clinical topic. Actually, it's also about society, systems, and justice. And then we will move into we will identify the gaps where this we'll see the gaps, and then especially I think you all be interested in how to do in research in these uh, gaps. So I think across all countries including Sri Lanka, health outcomes are not equal. Some people live longer, healthier life, while others face barriers even reaching care. It is similar to, I think, we are from South Asia. I think it's all over the world. It is same. Even even if you take example in a European country, not everyone is getting the right care at the right time. So today we will discuss what health inequality means, who are the marginalized population, and why these inequalities occur, and what we can do about them. So anyway, please feel free to share your thoughts during my session. So why do some people live longer than others, even in the same country? So this is a question. I think we need to think about. Sometimes we don't think this thing. I mean, we just live. I mean, even though our surroundings, if you are living in an urban area, your neighbors and your community is having a good access to healthcare. But even though in the same country, if it goes to periphery, sometimes people are suffering. And also we must understand health is not only biological, it is a socially produced. And first, factors like income, education, location, access to services, all influence health outcomes. So now with this picture, you can understand, you know, even the present world, current world, even during this war going on in Middle East, the top 1% controls 46 of the world's wealth. And also you can see in the war what's happening. The power and uh, the access to power always take decision, even though it's sometimes right or wrong, uh, others suffer. So different communities experience different health realities, and the health gap reflects development of this gap, this thing. For example, in Sri Lanka, if like I'm talking about Sri Lanka, so in Sri Lanka, an urban area resident, I mean, may have access to all the specialties, but a rural patient may live long distance, and sometimes they don't have nearby doctor to get the access, or uh, he might need a vaccination center. He has to travel far away place. So it's not same in everywhere. And the globally also similar difference exists even within cities. So I want to emphasize health is shaped by social condition, not by the diseases. So what? So just tell me. I'm asking from the audience. What factors matters most in your setting? Anyone? Okay, I'll give another example. We'll see. Uh, well, if take example in UK or USA, you know what it is life expectancy. You know the life expectancy is when you are born. The how they are calculating how many years you will live. So even in the UK or USA, life expectancy can vary even between county to the state, county to county, or state to state. So uh, the difference is persists, but when you consider all the, I mean, when you are taking as a whole, it it may not reflect the real picture. So, what do you think about your own country? So I'm from Sri Lanka. So we live in an urban area. We have access to I'm in Colombo, but we have all the specialized hospitals in here. If you get a cancer patient, we have access to a specialized cancer hospital. But if you take a peripheral area, a rural area like Mullaitivu, 300 kilometers away from Colombo, they don't get that specialized care. They have to travel to Colombo. So it's not about the disease, because uh, if you are living in Colombo, you can get easy access. You can get the treatment. But in a peripheral area, because of your setting, you will not get that same treatment or same. Hello,
Yes, doctor,
hello.
we can hear you. Uh, there is one thing. There are few participants are raising their questions in the chat platform. Doctor, it's better if you can check the chat as well.
Okay, yeah, sorry. Uh, uh, yeah, but how we can commit the social welfare? Yeah, well, I think this is regard. Miss, like, sorry about if I can't pronounce it properly. How we can contribute towards social welfare? Well, I mean, definitely, as a citizen, first of all, getting the proper knowledge is important, and also you can with your health, and also about other health. I mean, your family, and getting the right knowledge. So one thing is getting knowledgeable, and then there are various ways. I mean, uh, if you are working in the government, uh, uh, there are a lot of programs. Even I think everywhere is same. You can uh, uh, contribute your expertise, or you can go voluntary and go and help them. And also I think another piece, uh, another area, actually we are, I think, more into the research. So basically, now these things, now we are saying now, I took example saying that living in a urban area is not same as the living in a rural area. So and we are saying the access is low. Well, we need to go do more research on that and see what they feel about, and actual what are the gaps, and then uh, by like just seeing saying, okay, this is the gap, so we have to do this to make it right. But actually we need more research on these things. So especially we have to get their views from the rural area, how they feel regarding this. uh, yeah, they are asking unemployment. Yes, correct. The perspective for health divide in global south is applicable in Asian countries. Good. Yeah, I think, shall I answer them later? I mean, like, then, hello, Miss Hansini, yes.
Yes, it is possible, doctor.
Yeah, then I think it will be easier because we will have a Q&A session later. Yes. So I was talking about uh, uh, I was just drawing the your attention to why this health is actually always we consider sometimes. Hello, can you hear me?
Yes, doctor, we
Hello.
can hear you.
Yeah. Okay. So again, we were in this slide, I think. Yes. The so these slides, I think again I will explain a little bit of this. This slide reminds us that different communities experience different health realities. So I was explaining about giving example in Sri Lanka and also USA or UK. The life expectancies differ in state to state or maybe county to county. So then, uh, I want to ask whether this can health outcomes ever be truly equal when living conditions are unequal? So that's a question we should answer. So in health inequality includes unequal access, unequal quality, unequal awareness, and unequal outcomes. So you can see this is a multi-layer thing. Uh, we always say no, okay. Health services alone cannot completely erase inequality if the wider social conditions remain unequal, because health services can't control all these factors. Hello, hello.
Yeah, doctor, I can hear you. Hello?
Yes, can't you hear? Hello.
Yes, yes, we can hear you, doctor.
Sorry. Hello. Yeah.
Yeah, it's
Uh,
okay.
so here now we'll say example. Two people may both technically have access to a hospital. Again, I'm referring. But one may receive fast service, better communication, and more accurate follow-up. But another may receive delayed, fragmented, or poor quality care. So, equality on proper does not always mean equality in reality. So, another examples I must take. Uh, Access examples. See, one patient lives, again, I'm referring to near a hospital, another travels 4 hours to get the same service. And the second, unequal quality. Examples say one patient gets a specialist review quickly, and another only sees rotating junior staff with delayed referral. So one is getting quick access to the specialist, but another is the junior staff seeing a patient and referring to a specialist is also not getting the proper quality. An awareness example, one patient understands symptoms and screening, and another does not when to seek care. That is why I emphasize in the first place health, getting knowledge in your health and the. Can you see my video? Hello.
Yes, doctor. Now we can
Yeah,
see.
yeah. Sorry. So uh, uh, another, this quality care is more important. So then we'll say now uh, outcome example. Say one survivor. Uh, One survives because early detection of the same disease, and another presents late and dies due to, even if it is detected early, he could have been saved. So that's another example of unequal outcome. So uh, like this inequality is multi-layered. So again, uh, this the example I spoke about early. So then this is the most important factor. Many individuals do not access healthcare service not only because they are physically inability, but also due to the psychological and social cultural factors. First, fear of diagnosis. Especially, I have seen in healthcare settings, especially the healthcare staff, because they are they have seen maybe the worst scenarios. We see the cases they are neglecting their own health. Maybe it's the fear of diagnosis, uh, cancer, and chronic illnesses. And then sometimes people might fear the fear of medical procedures or the hospitals, or sometimes fear of financial burden. Well, because if I get diagnosed with disease, then how can I pay my medical bills, and how can I pay my child's welfare or child's school fees, uh, because the financial burden is everywhere. So fear leads to a delayed help seeking behavior. And then the stigma, the sometimes mental health stigma, or maybe HIV AIDS related, or then the social judgment about certain diseases. Example, leprosy is a one example. Uh, so again, stigma can result in make seeking uh, 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 proper care, no, unable to seek proper care and quality care at the right time. So this results in concealment of illness and social withdrawal. And then the cultural belief, uh, preference for traditional healing practices, misinterpretation of diseases might cause, like with your cultural belief or the traditional medicine, traditional practices will cause you misinterpretation of diseases, and also religious or spiritual explanation for illness. These all affect uh, people do not access healthcare service at the proper time. And also the gender norms. Women's are restricted mobility in some communities, men's reluctance to express their vulnerability, and unequal decision making power in families creates gender based health inequalities. So, uh, well, we'll say now uh, another example is disability. So, uh, the in your area, what do you think now? We are in Sri Lanka. I know there's another in this current presently. We are also discussing about this. Uh, our transport is whether the public transport mainly is it suitable for disabled person? Whether we and also think about the public uh, government. I mean government institution, maybe public area, whether we are providing right facilities to the disabled people. So they feel they have been neglected. So it also cause, I mean, disability, make them mm, is, I mean, uh, it it also we are not giving the proper facilities to them, make them not seeking the proper care. So this is an area actually we can see. I mean, you can do audit in your hospitals, whether the accessibility is given properly given to the disabled person, and maybe the result of your research will be surprise you all. And then the health literacy shock. Why it's a shock? Well, you can see this picture. Sometimes we think that we understand everything. Well, mostly we don't identify our conditions early because we don't know what are the early symptoms. And mostly with this current context, there are a lot of misinformation and disinformation. Uh, so with the social media and the internet, so people are relying on them. Ultimately, it causes delay medical health. So ultimately, sometimes early detection can uh, prevent, or maybe uh, even sometimes 100% the person can be cured, but delaying getting the default in the health literacy or not knowing right facts ultimately causing delay medical health. Ultimately people are getting, I mean, people are suffering from diseases. And then so all these relate to the social determinants of health. So that's why we always say the health is related to a lot of things. So we always think housing, proper housing, the right environment, income, employment, education, and there are more. I think you can put in chat box. I just put you here. You can see it's like a web. I mean, the heart is in the center, but it's like web, and all are interrelated, interconnected. One determinant fall in one determinant. Let's say example, education. Education. If you are not properly educated about your health or about your diseases or about your current context, ultimately your health will suffer. And if you don't have proper housing, it doesn't mean that you need to have a big house or what the big mansion. It's whether about you having a clean, hygienically and proper ventilated place and proper place to sleep. That's important. And the environment. Uh, Maybe urban areas you see now with our current present, or even in Sri Lanka, we are facing this. Our uh, air is not good. I mean, uh, the polluted air been like now the uh, uh, the rich, I mean, all the rich people are staying in urban areas, but we are breathing a polluted air, causing chronic diseases, asthma, making asthma worse. I mean, even leading to the cancers. So this is it. I mean, the environment and the income. Also, financial burden is, we always tell about this uh, social welfare, and we need to have a proper network to uh, safeguard the poor people or the government funding, because income, if you don't have the proper income, you don't think about your health, you think about how you eat and your how to take care of your family. And then the employment, it's the same. So and also we talk about gender. In our areas, women may face nutrition neglect, and sometimes they can't take their own decision in the current context. And reproductive, I mean, in culture, the cultural belief and the backgrounds. So they are on risk with these factors. And also, men may face, they have to face occupational hazard, maybe due to severe uh, conditions, their work, their employment, or maybe the financial burden, the mental health suppression. So health inequality has a gender psychology also. Just I want to draw your attention to into that. So then what we can do uh, from the health perspective. So say in Sri Lanka, I think our public health is very strong. We have a good public health system, especially it's provided by the government service. Uh, so to reduce this inequality, we need to empower more on preventive healthcare. So examples, vaccination programs, sanitation improvements, nutrition education. Because we always believe prevention reduces inequality faster than treatment. And well, some people may uh, uh, think in different way, but now Sri Lanka has eliminated polio. Sri Lanka has eliminated uh, 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 recently uh, I mean, we are eliminated malaria. So all these things are done through the proper preventive healthcare programs. And that is one way as a government or maybe even private partners. It's a one area we can easily reduce this inequality. And then the community health innovation. So now I have given some examples, modern approaches, mobile clinics. Now, let's say now uh, specialized care, like we say, if subfertility, because we don't have uh, specialized subfertility consultants in everywhere. But if we can have a mobile clinic with uh, conducting a satellite clinic, is going to a rural place in a roster and conducting clinic. And also, if we train a junior doctor to be placed there, and through telemedicine, he can communicate and can give his specialized care to the rural area patient. So again, we are reducing inequality by using innovation and new technology. Because telemedicine is not a very expensive thing. We just need to have a clinic, a place. Then I think with one, uh, I mean, giving infrastructure facilities and the equipments to a one place, but we can provide different care because the different specialties specialists can take their, I mean, can give their expertise to through telemedicine. People, they don't want to travel, or uh, they don't want to come to a specialized clinic and waiting hours, maybe days and days, or maybe they have to rent a place and stay to just to see the doctor. It will be reduced. And also we can train health volunteers, community health volunteers, who can go to house, visit house to house, and empower people. And this is one area we were success in maternal uh, and child health in Sri Lanka. We have good health indicators, uh, especially in MCH, maternal and child healthcare. Our maternal mortality, newborn, infant mortalities are very good. Uh, it's it's a it's mostly due to a PHM, public health midwife, visiting each house where the kids, the child, and the mothers, and they are giving their service at their doorstep. So these practices, I think we implemented way back. Seven, our first MOH was started in 1930, way back 1930. So then after that, now it's almost 100 years, now 95 years now almost. So, but still it is same. I think that those things will be in well practiced, and we are seeing the results. So even with the current contest, we can do it. Maybe we can't provide jobs for the government can't provide more jobs, but we can train community health volunteers. And then digital awareness campaigns. I mean, especially now the mobile phones are very common in these days. People, you know how to use mobile phones. So through mobile, create mobile apps for your, I think we have this lot of people are using to monitor their uh, vitals through mobile app, and how to and their exercise program. But if we can aware, especially uh, the rural area, the people who don't get the proper knowledge, by using digital awareness, we can reduce the inequality. So all this will reduce geographical marginalization. And then I want to draw your attention. There are a lot of research opportunities here. Especially, I think uh, this journal also uh, considering a lot of I mean the marginalized communities and social justice is so this is a good opportunity for you all to do your identify these gaps and do proper research. I mean, we are just talking about the facts, but you need to do research and see. There are some, always we talk about the tip of the iceberg. But a big portion is underneath. There are a lot of root causes. So uh, we can do, I mean, in this way, in health inequality index development, mental health services accessibility mapping, disability inclusive policy evaluation, social stigma impact on disease screening. This is, I think, areas we don't see much research being done in past. So there are research opportunities you can use and come up with a good result, good, and then I think you can even publish your research in the journal. So we always, when we are doing research, we have this ethical responsibility. Researcher must ask who left behind, especially when you are considering about marginalized communities and health inequality. Researchers must ask who is left behind, who is unheard, and who is invisible in data. That's the more important because doing a research, uh, gathering data, you go visit to a rural village and asking about people. Okay, what is your opinion about your healthcare? What are the? It's not that. If you can stay there, and I mean, this is especially qualitative research where you can live with them and maybe 1 month, 2 months, and then you will understand their real issues. Uh, there's a research done, very good research done now. One of our professors in Sri Lanka who stayed with beggars. I can't remember the exact years. Then he did a research. So he identified real problems and what are the root causes and what are they facing, their lifestyle. So again, not touching the surface, but you have to go beyond that. And then only you will find real picture. And then again, when you are talking about inequality and marginalized population, you must maintain the ethics, moral, integrity, honesty, and giving the right information and choices. Ethical practices is a must. And it's your responsibility as a research, especially when you go to a marginalized and community, it's you must maintain 100% your ethical practice. So just identify in your country, maybe even in your area. Let's say in a urban area, example, one vulnerable population, maybe the people who are in shanties, or maybe people who are living in uh, uh, apartments. Sometimes, even urban area, there are areas, these vulnerable populations being placed. And so you don't want to travel far away. So identify one vulnerable population, maybe then one preventable health issue. By early detection, you can prevent. Now, example, this pap smear. By doing the pap smear, by early detection, you can prevent carcinoma of cervix. So, likewise, there are a lot of things we can do. So, one preventable health issue, and then one innovative research idea. Maybe you might come up with a innovation to reduce and how to touch this marginalized community and to reduce inequality. So I must say health equity is not charity, it is justice. Uh, yeah, that's it from my side. uh, I just wanted you all to have I mean, it's not just a typical, lot of theories. It's about, we know this fact. Always this marginalized communities, marginalized population, vulnerable population, we always think and act on them. But actually, the government, in the private side, all people in the non-governmental organization, charity organization, we always think and act, but still the problems are persisting. So that's, then are we addressing these issues in right way, or maybe the right time, or maybe the right place? That's a question. So that's where you have to do a research and identify real gaps, and through that you can provide the real sustainable solution. Yes, yeah. Then thank you very much. Then shall we? Are there any questions? And it's just not questions. You can uh, make your opinion, and you can, because this, I think we have a I mean, participant from various part of the world. So, but I think is whether the rich or poor, the country-wise, we always see is marginalized communities, whether it's marginalized being happen maybe because you're disabled, or because of your health illiteracy, or because of you are getting misinformation, or maybe your cultural background. So it's a common problem. Yes, Hasini or Diniti.
Yes, I think now participants can raise if they have any issues with the lecture. I mean, the if more clarifications needed. Now it's time to raise your the questions, and doctor is there to address the questions related to marginalized communities and the health sector. So you can ask now.
Yeah, then well, I think uh, say any questions. I think again and again, I want to emphasize this. We always sometimes uh, when you are like especially doing a research in this regard, just remove your baggage. That's one thing I want to tell you all, especially because sometimes when you are thinking about this marginalized communities or this health inequality, you take your baggage. If you are taking with your baggage, then you will not think in the right way, because there are so many research and so many solutions being given to us, but still this inequality and this, I mean, this problem still persists. An example, even in the health sector, I made this example before. So, uh, recently, we also found a doctor being, he got a heart attack. He he had these health problems, but he neglected. It's one case because of the fear of being diagnosed and because he feared. But then again, if he had seek the medical attention, if he had uh, uh, or even if he had talked about his stigma, I mean the fear, then if we could have done a proper counseling. So it's everywhere. And why these people? I mean, then we can say no, because he's a doctor or medical person, he should have taken the proper care. But I mean, there are things we don't see from outside. So that's why I think, you know, oh, you have to think in every angle and uh, and remove your baggage. I mean, let's say the facts being known, okay, this is the problem, this is the solution. And if you can do a proper inner research, maybe you will find the real gaps, and then we can provide real solution. Yes.
Uh, can I ask my question, please?
Yeah.
Thank you a lot for your lecture. I really liked it, and I really like the question you raised about research and in health. And I would like to ask about what intersection of research field are used. For example, I don't know, the research in health area, they are like intersection of economics, social, sociology, or other transdisciplinary sciences that are involved, and what methods do you usually use in order to make this research like it's more like interviews, or it's more like quantitative research, etc. It's very and on which theories these research are usually based.
Yeah, I think in that case, I think qualitative is the best. I think because uh, I will say it differs. I mean, like if you take an audit, I mean, now you are doing an audit about your the government or the hospitals in your areas, how they provide access to the disabled person. That's a very simple way. I mean, quantitative way. You can use the quantitative methods, and it's a simple result. But again, and you are going to a we'll say mm, mm, the social workers and identifying their problems. So in that way, I mean, it's sort of qualitative. Maybe you have to stay with them and you, uh, feel what's real issues of, I mean, real situation. Maybe so it's in that regard, it's qualitative, and also this is interconnected with its health and then social. It's, I mean, if you are uh, concentrating in one area, uh, you might not get the right picture because all these are interconnected. That's why we are it all about this social determin I mean the health determinants. This is interconnected. It's like a web. So, but especially I think it's the qualitative part you have to do and do interviews and talk with them, stay with them, experience, and then you might identify the real picture.
Thank you. Thank you a lot.
Okay. there's another is a very interesting research. I can't remember if Miss Hasini can remember the professor's name, because he did a research on beggars. He stayed, I think, 1 year. He was stay with them. They didn't know he was a professor, and then he did a nice research, and through from that he got a very I mean, it's very interesting results. uh, Hasini, can you remember? I can't remember. It's not clear to my this thing social, because I'm from the healthcare side. Hello, hello.
Yes, give me a second, doctor. I'll let you know.
Yeah, but it's time consuming. It's difficult. It's very easy, to do a audit, or
Yes,
give
it's Professor Nandasena Ratnapala.
none same
Yes.
Professor Nance. I think he has a published a book, no? Yeah, yeah. Got it.
So if you have more questions, now you can raise in else you can raise your hand, and also you can drop a message in this chat. You have both options actually.
I also can give some, I mean, research, I mean, areas. I'm not saying special. Like example, go to a vaccination clinic. Yeah, I mean, then you can do audit. Uh, how many uh, uh, people are getting vaccinated at the proper time. I mean, the or maybe the areas they are which they are coming from, and their I mean, literacy. I mean, health literacy on why, I mean, background. So that's a simple audit. It can be done easily. Take a 5 or 6 clinics with proper methodology, I would say. Then you can do audit, and then you can see why others are not coming. Maybe the people who are not attending to the vaccine clinic, which population, or whether it's due to the transport barriers, or maybe due to the health illiteracy. These things can be seen, and also you can see whether actually they are being taken this vaccine because of they know what they are taking, or because of the practice, or the influence by the others. These things you can identify.
Yes, doctor. I have something to clarify here. So, when it comes to medical related research, even it is a social science research. So, I think there is a specific procedure. There are specific procedures when it comes to health ministry and the health field. So, if we do the data collection, from patients or in the medical institutions, so there is a certain kind of procedure. So we have to follow up related to ethical clarification. So in here in Sri Lanka, so what kind of procedure is there to follow up, and a person who is interested in medical related, let's say research with the disciplines like marginalized communities and the health sector. So if somebody is willing to integrate these two fields and do a multidisciplinary research, so how can they get approvals from their ethical clarifications from the Ministry of Health, or the other from the other medical authorities? So how can they proceed
Yeah,
there?
yeah. I think in Sri Lanka is when talking about Sri Lanka is a bit of different. I mean, the government is providing. I mean, 95% of uh, almost 95% of inward care. So only the private sector is providing 5%, and our outpatient it's like 55 to 45. But basically, the government is providing curative and preventive care in Sri Lanka. So, in Sri Lanka, first of all, if you are living in Sri Lanka, you are a citizen, then it's easy. Then you can first you have to have your proposal, and then uh, it has to be some. You have to get ethical clearance from a registered ethical board. Mostly there are universities, and then I mean Colombo University, Japura, like main universities, government universities, and also there are associations like medical association, uh, and in some hospitals we have established ethical committees, review committees. It has to be registered in Ministry of Health. So then you have to get the ethical clearance. With all these ethical clearance and with the proposals, then you have to submit to the Ministry of Health. And we have a unit called uh, uh, Research and Training Unit in Ministry of Health. Uh, when you are submitting to a when you are submitting your research proposal with ethical clearance and everything, all the documents, then they will review your proposal, and if they are I mean if it is okay, or maybe if they need more clarification, they will give a I mean they will provide you a time to discuss these things and appointment. And after that, the Director General of the Health Service, uh, through the recommendation of this ETNR, that's the research unit, the Director General of Health Service can give the permission. This is I'm strictly speaking about if you are collecting data in government institution. But if it's a private hospital, still you need to get the clearance, but you don't need to get the Director General Health Service permission. And we have a National Health Research Council, and now we are on the process of updating our guidelines, because in especially in medical field, it's sometimes it involving with the biological uh, uh, I mean biological and clinical aspects also there. So we have to there are in if you are taking samples of blood samples or clinical samples, biological samples, then the process is bit uh, I mean I'm not saying it's difficult, but there are more things being required. And but again, if you are a person from outside of Sri Lanka, then you need to have a collaborating partner and from Sri Lanka, and then again there should be agreement, proper agreement. And also then if the Ministry of Health is involving, mostly though that will be referred to if we are sending sample outside Sri Lanka, then we have to thoroughly go through it, and then we have the legal officer in the Ministry of Health. They will be check these agreements and these proposals, and will give the permission. So that's uh, it's bit of different, I think, in other countries, because we are actually governing the mainly we are the sole player in the in healthcare setup in Sri Lanka. Yes, you need more clarification, or is it enough? I mean, you can submit this proposal to the Director General Health Service or the Secretary of Ministry of Health. You can write them. So then this proposal being properly forwarded to the unit, and then they will review, and after that can go through it. After the permission, you have to go to the particular hospital, but with this permission, you will be able to access to uh, to uh, to your I mean your whatever the samples with the patients or other area you wanted to uh, do the research.
Uh, Doctor, I have to add something to the previous question. Valentina asked a question about the intersections of economics and healthcare. So I think we can, if we think like now, say the income distribution of the patients, and the relationship with the income distribution and their healthcare patterns. Right? If they are down the poverty line, then their healthcare may reduce. So we can set a hypothesis saying that there is a relationship between the poverty level and their healthcare standard. So uh, I mean, we can just see that from the face of it that there is a certain relationship with income level and healthcare. So we can just test that hypothesis. So for that, we can use quantitative techniques because that is straightforward. And when it comes to this lower income levels, there are some other things. I mean, other issues, nuance issues are there because uh, so like due to their lower income level, they don't get proper education. So there are some interactions between other variables as well. So when you find out those things, once you find that there is a problem, then you can go into interviews with the patients, so that the patients will you can get their emotions and their lived experience and everything through in-depth interviews. So first part is the quantitative part. You can uh, enhance the breadth of the study, and then after that, you can enhance the depth of the study using qualitative methods. So then you can just balance your validity. The causality, you have to isolate the causality. Now there is a causality between income and their healthcare standards. So that the first part is using quantitative, you can verify that there is a certain kind of a correlation, and then causality has to be verified using control group or something like that. Then when the causality is verified, you can go into more in-depth interviews, like qualitative interviews, and get the holistic picture. So that is in a research perspective, that's what I mean, that is my value addition to that. So if you have anything to add to that, doctor, please enlighten us.
No, that's fine. That's fine. It's a good explanation. I mean, it's a good answer. Yeah. Thank you.
So, any more questions? Doctor, can you unmute?
Sorry. No, there's a one question. It's about bias and neglecting clinics. What methods can ensure more dignified and equitable care for marginalized groups? So, one thing is you can promote, uh, I mean, uh, this patient-centered care. That means, respecting their uh, values, preferences, and cultural backgrounds, and ensure privacy, confidentiality, dignity, encouraging shared decision making, and always, providing proper, proper respectful for their, uh, always keep for their condition, their during their with their interactions, and also you can uh, 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 do conduct maybe uh, in maybe conduct regular training programs, maybe training on so you're asking some bias, then you can uh, 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 hire research assistants, and train them properly. It's one way, I think. I don't know whether I have understand your question properly. Uh, and also use simple language. Mix with them. You know, that's always important. Mix with them properly. If they feel you are one of, empathy is must, not the sympathy, empathy. So if they feel you you are not a sympathizer, but you are in empathic way, you are involving with them, I think you can do a good research. Yes.
Hello, sir. I'm Sukriti here. Actually, this question was about, sorry, I'm from India and I'm working with sanitation workers in India. And basically, the work is caste-based in India. So mostly these biasness and this kind of, pollution thing, it's related to dirty work. So sometimes people just, neglect them. They, mostly in clinic setups, basically because of their caste, because of the type of work they do, the kind of, dirty work, what we quote it as a dirty work and pollution in India. So that is the reason I was asking you, because the first question I asked you is about the, any model or any kind of practices, there in Sri Lanka, which can help in proper healthcare access and responsiveness of this marginalized group. And the second question was about the biasness. The sometime, the medical staff they are not getting the proper treatment because of these two factors. The first is caste, and the other one is of the dirty work they do. So I was just asking this question, how can, because whenever I go and ask them, why you're not going for the, checkups and everything. So the first question is, the first answer is, we don't feel comfortable. They don't treat us equal. They don't treat us in the equal way they treat others. So this kind of biasness, actually, I wanted to discuss with you because it's common in India. So I'm not sure about Sri Lanka. I'm not sure about these factors. So that's what I was asking you about.
Similar thing, I think, what our Professor Ratnapal, sir, I mean, he did sort of that thing. He did research on the beggars, I think, because no one knows he was a beggar, so that's a difficult. I mean, it's a difficult, and it's a different sort of approach, but it will get the real picture. So get the real reasons. Uh, Maybe audience must be like can give some suggestions, but in a way, Sri Lanka's model. I mean, we always that's a problem. Sometimes they always when you ask questions, they give the most negative feedback. So, but then again, if you can like go in a 360 degrees, I mean, you are interviewing them, then you are interviewing their supervisors, and then you are doing observations, and without asking any questions, you are observing them, and again, if you can train a person from them, uh, 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 and uh, and then from through his I mean that through him, if you can get some ideas, I mean, you can get some video recordings, maybe interviews, ask him to record, just and uh, that's way, I mean, like not just interviewing or seeing, but using different ways, and then ultimately it can, you can do a thematic analysis, and then ultimately you can get a real picture. Maybe others, they can. Mr. Madhura, you have anything to add?
Yeah, now Professor Nandasena Rattapala, you mentioned about him. Actually, he has been a beggar for 2 years. He just wore certain clothes, and he was in bus stands and everywhere. So he observed the beggars and how they behaved and everything. So he wrote a book, I think, a book also
Yeah.
on that. So that is a good way. I mean, when you ask questions, I mean, when you distribute questionnaires, the people know that you are doing a research and all. So they get the feeling that they are being judged. So they don't give the proper answer. They give a biased answer. Even if you are doing a qualitative interview or any thing, what happens is the people will understand that this is a research, so they are not going to reveal the truth. So if you can just go there and observe the situation and behaviors and everything, so you can get a lot of juicy things. Like really, you can see the reality. You can experience through your eyes the reality, how the people behave and everything. So I think it is a very effective method, but you have to be very patient. That's the thing.
Yeah, that's it. You have to be very patient, and to get the real picture, because in other way it's very difficult, and you can do this. I mean, that's why if you can get friendly with one person, maybe I mean, it's sometimes he had to do it ethically. So he will like get friendly with him for a period of time. So sometimes he might give the real picture, not just one day you give a question and then next day you collect the answers. Not like that. You can't do like that. They will not give the real answers. That's why it's difficult. I mean, there are research being done on this. I mean, marginalized communities, health inequalities, but I don't know whether how many research has been done it properly and how actually in a proper way, whether they have identified the real picture. Uh, Hasini there, yes. Then and also, I think you can use, the snowball method. It's a one way of you can do research on this sector because sometimes it's difficult to get one. It's getting friendly with one person through him, getting another person through him, another person. That's another method you will be able to use in this sort of communities. Uh, and shall we wind up?
Yes, Dr. I think we have discussed a lot. The session was very interactive, and actually it was very interesting to have so many ideas from all from the participants all over the world. So here, yes, now based on the insights we collected from the session, so we are able to do something new, and I guess most of the participants will be able to think more regarding these health aspects and how to uh, clear their ethical requirements, and at the same time how to go to the society and how to address them and to collect data. So, and at the same time there are we discussed something new, especially related to Sri Lankan context, the Sri Lankan healthcare sector. And so I think you will be able to think more and come up with good and innovative ideas related to healthcare sector and marginalized communities, and at the same time social justice as well. If you can integrate these kind of disciplines, so it will be very interesting thing to yes, discuss further. So we extend our sincere appreciation to our distinguished resource person, Dr. Madhav Dharmadasa, and for sharing his valuable insights and expertise on health inequity and marginalized populations. His contribution has greatly enriched our understanding of this critical area. We also thank all participants for your active engagement and commitment uh, throughout the session. So your enthusiasm and interest are truly appreciated, and we look forward to your continued participation in the upcoming sessions for the Journal of Marginalized Communities and Social Justice lecture series. So thank you very much. Have a good day.
Thank you. It's a pleasure to join with you all. Thank you. Good day to everyone. Thank you.